Good morning, Dr. Karen Box. Do you hear me? This is Dr. Cao. Good morning and good evening, everyone. I think it's about time to start the Transoceanic Symposium in Periodontology and Prosthetic Dentistry. I know there are some alumni here and states from Tufts and Harvard on the website seeing this conference. First, I would like to express my sincere appreciation to all participants, either here or on the website, and all contributors, speakers, and the host today, Professor Shi Wenyu, the Department Chair of the Taipei Veteran General Hospital. Especially, I would like to express my highest appreciation to the great support of Professor Nadim Karenbach. Nadim Karenbach is the Dean of the Tufts University School of Dental Medicine. Now I will go on introducing the first speaker, Professor Nadim Karenbach. He is also a Harvard alumni. He earned the DMD degree in Harvard School of Dental Medicine in 1991 and the Master of Science degree in oral biology in HSDM in 1993. And Dr. Nadim Karenbach was appointed the Dean of the Tufts University School of Dental Medicine in 2019. He also serves as a professor in the Department of Periodontology before joining the Tufts University School of Dental Medicine in 2012. Dr. Karenbach served in numerous positions at Harvard School of Dental Medicine, HSDM, including Director of Predoctoral Periodontology, Program Director of the Advanced Graduate Education Program in Periodontology, and in 1998, the Assistant Dean for Dental Education. Dr. Karenbach has served on the board of editors for the Journal of Dental Education and as Associate Editor for the Journal of Periodontology and Metaportal. He is the editor for the Journal of Dental Education and the online editor for Karenbach's Clinical Periodontology textbook. And Dr. Karenbach has received numerous honors during the academic career, including the GW Tufts Award from the American Society of Dentistry for Children, the Periodontal Education Award from the American Academy of Periodontology, and Distinguished Faculty Awards from Harvard School of Dental Medicine. In 2010, he received a presidential citation from the American Dental Education Association. He has published more than 100 papers, articles, and authored textbooks, and lectured worldwide. And hopefully, he may come to Taiwan next year. In 2015, he received the Provost Award for Outstanding Teaching and Service from the university. Of course, now, as our first distinguished speaker today, Professor Nadim Karenbach is going to give a lecture on the topic of overview of peri-implantitis. Please give Dr. Karenbach a warm applause. And thank you, Nadim, please.
Great. Can you hear me?
Oh, of course, no problem. Very clear.
Yeah. Okay. Well, thank you for the kind introduction. I know it's early morning over in Taiwan. It is evening time here in Boston, a beautiful time of the year, with summertime now in Boston. So this evening, I'll give you a very quick overview of peri-implant mucositis and peri-implantitis. It is indeed a challenge to try to cover all of this area within a 20-minute period. Normally, when I give this talk, it can last almost 2 hours. Before I begin, I would like to give you a brief introduction to the Tufts University School of Dental Medicine. You can see here the picture of the university. It's right in downtown Boston in the Chinatown area. When I became dean in 2019, I spoke about our passion or our vision, which is global leaders in oral health. We train the world's dentists. We are the second largest dental school in the country with 800 dental students, 60 international students, and about 150 residents. When I talk about training global leaders in oral health, it's really in our residency programs that we've had a great track record, with many people specializing in different areas from Europe, Asia, South America, and so forth. We have 3 mission statements. So our purpose is education committed to clinical excellence, knowledge to not only improve oral health, but general health as well, and then care and community. And our strategic plan is called Imagine 2030, powered by our passion, purpose, people, place, and partnerships. We invite everyone to create our future. We are indeed lucky to have 10,000 plus living alumni who are also very, very supportive of their school. Before I begin, I have done some consulting for different companies. They're listed here. Nothing that I'll be presenting today has any kind of conflict of interest in terms of the work that I've done for these companies. Now, normally when I'm doing this presentation, I will show my audience this clinical picture of 3 dental implants placed in the lower right quadrant using the American tooth numbering system. This would be considered teeth 28, 29, and 30. And I would give my audience about 3 or 4 minutes to think a little bit about what their clinical and radiographic interpretation is. Because clearly the clinical structures around implants are different from what we would see in a normal periodontium. We talk about normal being salmon pink color, knife-edged margins, pyramidal papilla, but we recognize the structure of the soft tissue and the relationship of the soft tissue to implants is slightly different. And radiographically, you might look at this area and notice some kind of patterns of bone loss. So my message to you is that our clinical observations are critical for diagnosis around implants, and our radiographic interpretation is also critical to diagnose disease. Having said that, there are some differences, and I'll go over these very quickly with you. So again, our clinical exam should consist of our traditional examination of tissues. We can observe areas of redness or health, for example. We should do periodontal probing. And in the very first years of implants, we were told only to use plastic probes, but we understand that plastic probes have a certain shortcoming, so using metal probes is good. And we recognize that our clinical signs of mobility around teeth cannot be used around implants, because mobility around implants typically means either a restorative failure or failure of the implant. Our radiographic interpretation is important, but again, this is typically relative to what we might see after 1 year of loading, because we all recognize that in the first year of healing and loading, there can be typically anywhere from 1 to 2 millimeters of bone loss experienced around certain implants. So it's always important to have that historical context of what the radiographic levels were over time, because everything that we interpret should be based on that historical kind of radiographic information. We need to think about risk factors like we do in normal periodontal disease, understanding that there are correlations between people that had a history of periodontitis and bone loss around implants. We recognize that uncontrolled diabetes is a risk factor. And we have some evidence that smoking is also a risk factor. We need to try to think about prognosis very differently, because again, you can have bone loss around implants, but without any kind of signs of disease. Implants are in a way ankylosed and could last many, many years. Some of you might have had experiences of thinking an implant is hopeless and trying to remove the implant, recognizing at the time of removal that the implant is still anchored in quite a bit of bone. And then we have to think about our diagnosis specific to where the implant is and its relationship in terms of the restorations that have been placed. And then finally, based on our clinical and radiographic diagnosis and thinking about etiology and prognosis, we need to think about our treatment plan. And there's no surprise here. Our treatment plan, just like treating periodontitis, should be a non-surgical approach and or a surgical approach, but with recognition that doing surgery around implants can be very unforgiving in aesthetic areas. So again, you need to keep in mind the area of the mouth that you're treating, the risk that you run when you do a surgery, because you will end up with a certain amount of recession. So normally I go through this in quite a bit of details, saying we have to understand what the anatomy and healing is around implants. We have some very clear definitions for diagnosis, and I'll give you these. To diagnose between mucositis and periimplantitis, I won't have much time to spend on etiology and prognosis. And then very, very quickly, just give you some kind of a thought around non-surgical and surgical approaches. So when we look at the anatomy of the natural tooth, and this picture, I think, captures really very nicely the differences. On your left-hand side, you see the relationship between the normal periodontium and a natural tooth. We recognize that there's some very unique structures, the sulcular epithelium, the junctional epithelium, the way the gingival connective tissue is got an orientation around the neck of the tooth. And we can see that there's a very rich blood supply that not only comes from the gingival connective tissue, but also a very rich blood supply that comes from the periodontal ligament. We also recognize in a natural tooth, the periodontal ligament has quite a few regenerative types of cells. On the right-hand side, you see the relationship between the implant and the alveolar bone and gingival tissues. And you recognize there are certain unique kinds of properties. One is there's no periodontal ligament. Two is we don't have a blood supply coming from the PDL. And the relationship of the gingival fibers to the implant is very different compared to the natural tooth. Keep these in mind because I'll show you a picture of the patterns of bone loss that we see normally around implants. And any of you that have seen these kinds of patterns of bone loss recognize they can be very crater-like and very deep and narrow at the base of where the bone loss is. And that's partly due to this anatomy that we observe. The other thing that we have to recognize is that when we probe, because of these differences, there can be a difference in terms of probing depth. On average, probing around an implant is about 0.5 millimeter deeper than what you see normally. And also, depending on the placement of the implant and the amount of soft tissue, a 5 millimeter probing around the neck of an implant does not necessarily correlate with 5 millimeters around a natural tooth. So again, when you look at your probing depths, it's critical and important that you keep this relative to when the implant was placed and when it was loaded. So for example, if I had placed an implant and I probed about a year ago and it was 5 millimeters, and I probe again today, a year later, and it's still 5 millimeters, I should be interpreting that as a relatively stable probing depth around the implant. So again, the take-home message for probing is it's a little bit deeper than normal teeth by about 0.5 millimeter. And you should always keep in mind what the initial probing depths were. So that's a very quick overview of the anatomy, the uniqueness, and how it can lead to interpretation and disease processes. Now, very quickly, and I won't necessarily read through these, I'm happy to give a copy of a PDF copy of my slides to the organizers. In 2017, there was a world workshop that was done in the Journal of Clinical Periodontology that talked about peri-implant health, peri-implant mucositis, and peri-implantitis, case definitions and diagnostic considerations. Here we see the diagnosis of peri-implant health. Again, visual inspection with certain characteristics, lack of bleeding on probing. And as I mentioned, probing depth can differ depending on the location and implant. However, if you do see increases in probing depth over time, that's an indication of past disease or current disease. And then just like with gingivitis around peri-implant health, you should see an absence of further bone loss following the initial healing, which should not be greater than 2 millimeters. Peri-implant mucositis, again, visual inspections, you do start to see some redness appearing. You might have some bleeding on probing. You could have increased probing depths compared to your baseline. But in this case, again, you do not want to see any relative loss of bone compared to when you first loaded the implant. And then peri-implantitis, clearly, you can see not only clinical changes, but increased probing depths over time, and then progressive bone loss over time as well. Now, this slide demonstrates for you the difference in lesion development. You can see on the left-hand side the natural tooth relationship. And in general, when periodontitis lesions develop, what you see is a kind of walling off of the lesion by the gingival connective tissue fibers. But because the gingival connective tissue fibers are not as strongly related to the neck of the implant as you see on the right side, you can see how the lesion spreads down into the alveolar bone and causes much more of a crater or angular defect. And in fact, you can see in this surgical presentation how that bone loss looks like. And again, many of you that have flapped around an implant recognize how deep and crater-like many of these lesions can be. And we can attribute this to the kind of anatomy that we see between the bone and the connective tissue. The other thing to keep in mind is the definition that we use between implant success and failure. And here you can see basically a scale that was published by Carl Misch et al. That shows basically success is optimal health. And this not only includes our clinical findings, but the addition of no pain or tenderness and no exudate history. Satisfactory are all the characteristics, except you might have had some bone loss from the initial surgery and loading. Compromised survival is sensitivity on function, bone loss, and probing depths greater than 7. And then obviously failure can either be clinical, where patients continue to have pain on function. There's mobility. Now, the letter C says bone loss greater than half the length of the implant. Now, keep in mind that this doesn't necessarily mean that the implant will be lost, but something that you must keep an eye on in terms of increases of bone loss. And then uncontrolled exudate, despite your cleanings or giving antibiotics, that's a failure. And then obviously the worst case scenario, and many of us might have experienced this, is when the patient actually comes to your office with the implant in their hand. Now, the prevalence of peri-implant disease after greater than 5 years of functioning from cross-sectional studies varies, but we can see that about 80% of our subjects will have some form of peri-implant mucositis, and more than 50% of the implants have been found to have some kind of inflammation without no bone loss over 9 to 14 years. What does this mean clinically? Well, it means you and or your staff, if you have dental hygienists, should be watching very closely for any clinical signs of redness or bleeding, and you should be treating these implants like you would for a patient on regular recall. And we recognize that with our non-surgical treatments, we have many different armamentariums that we can use nowadays: titanium scalers, ultrasonic scalers with special kinds of tips, wire brushes, etc. Now, if we look at the prevalence of peri-implantitis, it can vary based on the numbers of studies that have been done, but about 28 to 56% of all patients will have some form of peri-implantitis. On the low end, 6% of implants up to 43%. And again, you can kind of see some of the other data that's been published, and this was from the Journal of Periodontology. Now, the etiology can be mainly biological. We recognize that just like natural teeth can get plaque, implants can also collect plaque, and many studies have been done showing that the putative pathogens that are responsible for periodontitis are also the same pathogens that can cause mucositis and peri-implantitis. However, we also need to recognize that there can be mechanical and technical etiologies. Sometimes the mechanical ones are failures that we can't treat, whether there are screws that break or implants that fracture. And then finally, there can be surgical etiologies. So depending on how you place the implant, the relationship of the implant to the bone at the time of placement, that can result in what I would call misdiagnosis. So for example, if you were to place an implant in a bony socket and you knew that that's what you did, and you see a little vertical defect there, you might attribute that to what you observed at the time of placement. And then finally, our treatments are our traditional treatments of non-surgical and non-surgical. After we make our diagnosis, again, our non-surgical treatments should be thinking about mucositis versus peri-implantitis. Obviously, if there's compromised survival or failure, oftentimes that might result in removal of the implant. I would have gone through quite a few articles on the evidence that we have for how effective non-surgical treatments are for mucositis, but again, due to the shortness of time, we won't have time to explore that. And then again, for diagnosis of peri-implantitis, we can either do non-surgical treatment to begin with, reevaluate, and if we feel like things are under control, we keep our patients under maintenance. Or if we feel there are reasons to treat the peri-implantitis, we should treat with access surgery, keeping in mind that each area is unique. Our goals should be to halt the progression of disease, certainly think about regenerating what is lost by the disease, and aim for reosseointegration if we can, although we can't prove that without histological evidence. There are factors that can affect the outcome, such as surface characteristics of the implant, defect configuration. Our surgical toolboxes remain the same: open flap debridement, resective or regenerative therapies. And again, we can look at many different ways of treating defects. If they're well contained, regenerative therapy with bone alone. If they have three walls or dehiscences, typically we need a membrane to retain the bone. And then in some cases, our goal should just be to access the area, clean it, and eliminate pockets. And again, with multiple implants, you can follow similar types of guidelines. So with that, I know my time is up. We do have 3 textbooks that we've published over time. Many of these with my faculty and residents, both at Harvard and at Tufts. The first book is Clinical Cases in Implant Dentistry. The second one, Clinical Cases in Perio. And the orange one is the latest edition of Clinical Cases in Perio. I do believe my time is up, so I thank you for listening.
Thank you, Dr. Karenbach. It's a very wonderful and gorgeous lecture for us regarding this topic on peri-implantitis overview. So I would like to invite any participant here in the auditorium or on the website to give some questions regarding to this topic. I think that we have some alumni from Tufts or Harvard on the website. Dr. Huang or Alex there?
Hello, Dr. Nadine. Thank you for your wonderful lecture. I'm from Tufts in IS-94. I have been staying in Tufts for almost 10 years before.
Wow.
And then thank you for, we have a very good team now. Yeah, my question is that, as you mentioned, the peri-implantitis is always induced by the bacteria mainly. And from mechanical viewpoint, you just talking about the implant fracture or screw loosening. Do you think that from a mechanical viewpoint, if the case don't have any implant fracture or screw loosening, do you think the high stress scenario as a bruxism patient, they will have a more opportunity to going to have a peri-implantitis disease?
That's a very good question. I think most people are leaning towards the fact that there can be some contributing factors from bruxism or extra forces on the implants as well. I don't know that there's any clear or strong evidence, but I do believe that taking away even the restorative failures that we see in some of these cases, that those can be contributing factors. And I know many practitioners, obviously, when they're doing cases, are paying closer attention to occlusal forces, prescribing night guards, for example, even around implants, especially if you're doing your restoration on all implants. If there's early loading, paying attention to occlusion and keeping the occlusion lighter during the initial phases of healing. I was just mentioning we had a very nice alumni reunion CE course in Monaco about 2 weeks ago. Probably many of your colleagues that trained with you from Europe at that time, Perio-Pros people, were at that meeting. And there was a whole lecture on the mechanical forces and kind of failures that people see and how difficult it is from a restorative perspective to actually rescue those cases, especially nowadays with so many different implant types, implant screws, etc. But I do believe it's a contributing factor.
Okay, thank you. And now the society, a lot of aged people, they have some anti-osteoporosis medication. Do you think those medication will be another factor when we go to have those implantation, a risk factor?
Yeah, I think the bisphosphonates has been something that people have been worried about, especially the kind of necrosis that you can see post-extraction. The thought is that if you're getting consultations and getting kind of medical clearance, that you can still place implants. I haven't seen any long-term studies that have looked at implant survival rates in those kinds of patients, because each one is obviously unique. But I think most people will be conservative or cautious in those cases, and try to lower the risk wherever you can.
Oh, okay. Thank you, Doctor.
Yeah, thank you, Dr. Huang.
Thank you.
I have a short question. Regarding to the general maintenance, sometimes we use the ultrasonic scaling tip, but you just mentioned some special type of scaling tip. Is there any kind of scaling tip for maintaining the peri-implant tissue or special metal?
I have a picture of it in my regular talk, that there are some specialized ultrasonic tips that can potentially be used around implant lesions. I can again share that, with the group later on. The other thing that, we've seen is use of titanium wire brushes on rotary instruments. Because again, when you're scaling around these implants, if you ever flap them or try to clean them, you recognize how narrow and deep these lesions can go. There's some people that also try to modify the surface of the implants with a variety of abrasives, hair polishing. The problem is, I think, with all of these different treatments, there really isn't any strong, good, I would say, large-scale evidence on outcomes because every case is so different. So there's a saying that we throw the kitchen sink at all of these issues, almost like try all these different treatments. And again, this was a big part of the discussion that we had in Monaco a couple of weeks ago about, which treatments really are the ones that you can say are very predictable. The other issue that we find around implants is the relationship between the soft tissue and implant itself can be challenging to manage when you place a flap because that tissue sometimes can be very either tough or can tear very easily. And all of these are challenges just depending on the situation that we're facing. And as I mentioned, I think trying to do anything in an aesthetic zone, if someone has a high smile line, when patients have peri-implantitis, I think can be a real compromise, and most people tend to try to stay away from having to do any kind of surgical treatment in aesthetic zones and trying to maintain things non-surgically.
Thank you, Nadim. I know we have a fellow just went to Tufts to have continued education from Pros, Dr. Liu, right? So it's really a great chances for us to have a connection with Tufts University. Of course, I would like to invite anyone here to have any more query regarding to this topic or any other else. Any fellows from Perio or Pros? Or anybody, any participants in the online? Okay, so it's probably temporarily stop here. I really want to express my sincere appreciation to Professor Nadim Karenbach, the Dean of Tufts University School of Dentistry. It's a great chance and beginning of connection between NYCU College of Dentistry and Taipei VGH with Tufts University, and hopefully we can have more chances regarding to the connection or continuation in the future. And we'll have a short meeting on July 15 with your Director of Continuing Education online. So I really appreciate Nadim, and thank you very much today. Thank you.
Yeah, thank you for inviting me.
Thank you. Thank you. Now, I would like to move on to the next speaker, Professor Lai Yuling. Well, as everybody here on the website, I know there we have some alumni in States online, like Ye Mingguang. I've seen him and just have a talk a few minutes ago. So I'm very glad to introduce Professor Yuling Lai. Professor Lai is our very famous alumni of NYCU School of Dentistry. Dr. Lai earned the DDS in 1983. She was promoted as the first attending physician from Yangming alumnus in the Department of Dentistry in Taipei Veteran General Hospital. Now, Taipei VGH is ranked #1 this year as a national leading medical center in Taiwan, according to the Newsweek Worldwide Hospital Ranking 2024. And Professor Lai completed her Master of Science degree in Tufts University School of Dentistry, Department of Periodontology in 1996. She had the Diploma of the American Academy of Periodontology and Certificate in Periodontology and Dental Implant Surgery, the American Board of Periodontology. And Professor Lai honorably accomplished her 5 to 6 year leadership as the chair of Department of Stomatology in Taipei VGH in 2024. And Professor Lai also had a Great Achievement Award innovative medical techniques and services at the 50th anniversary of Taipei VGH in 2009. And in 2018, a Silver Award of Education and Academia, Taiwan Dental Association. And Professor Lai is a role model, I think, for our younger generations of dental society in clinical, teaching, and research aspects. Professor Lai is going to give a lecture on the topic of critical consideration for immediate implants. Let's applaud for Professor Lai. Thank you.
Good morning and good evening, everybody. Thanks for Professor Gao's invitation. It's a great honor to have presentation here. My topic today is critical consideration of immediate implant in the aesthetic area. Implant placement in the anterior area usually can get a good result. However, for the Oriental patient with thin phenotype or severe loss of the tissue, unfavorable result may happen, I think, in the case on the right. Patient was referred to our clinic due to the severe tissue loss post-immediate implant surgery. To achieve a favorable result and prevent the complication happening, we will address several critical points in the immediate implant, including implant positioning, soft and hard tissue management. In terms of the implant positioning, precise control of the implant position is very important in the aesthetic area. In the mesial distal direction, if the adjacent tooth has low proximity overcrowding, after tooth extraction, implant cannot be placed in the socket area. For this mal-aligned root, we got to redirect the drilling direction in order not to violate the adjacent vital structure. After correction of the implant position, implant have same margin with adjacent root and achieve a favorable restoration contour. In the buccal-parietal direction is more critical. Case study show that 81% of the maxillary anterior tooth root contact with the buccal cortical bone, indicating that most of the maxillary anterior teeth is near the buccal plane. After tooth extraction and the implant placed in the socket area, this thin labial plate tend to resorption, which may lead to the bone deficiency, soft tissue recession, ultimately compromise the aesthetic result. Therefore, in the immediate implant of the anterior teeth, we usually shift the implant palatably. Avoid directly place the implant in the socket area. The advantage of this approach include the screw access through the cingulate area rather than through the labial surface of the restoration. In the meantime, parietal engagement ensures the primary stability of the implant and provide a larger augmentation space at the buccal crestal area. Even though we want to do the parietal engagement, there is a tendency for the drill easily retract back to the socket area due to the resistance of the parietal cortical plane. To overcome this, we implement a precise drilling protocol, and start by dimpling the parietal cortical plane using a round burr to establish a stable starting point. Then we can use the precision drill to penetrate the cortical plane and control the initial drilling direction. Subsequently, when we use the twist drill, we can initially tear the drill buccally. During the drilling process, gradually tilt the drill back to the ideal parietal position. After that, when we press the implant, we can do the same approach. In the immediate implant of the maxillary anterior teeth, we usually combine with the osteotomy. We can use the osteotomy to separate the parietal plate and push it buccally. This technique will create a cortical plate, intimate contact the apical buccal portion of the implant, thereby secure the implant in the parietal position. The second thing is soft tissue management. Adequate soft tissue is very important in the anterior area. I will propose a couple of cases to demonstrate how to manage the soft tissue. We look at this crown fracture case. The patient was thin phenotype, and there was crystal bone loss of the adjacent tooth. At the beginning, we just remove the crown portion and let the labial gingival tissue corner growth for a couple of weeks before the immediate implant surgery. After a traumatic tooth extraction, a thin labial plate was left. For the patient's comfort, we did a all-in-one surgical approach. Implant placement combined with the soft and the hard tissue augmentation. After healing abutment connection, placing the osseous graft material, then covered with the subepithelial connective graft instead of barrier membrane covering for the aesthetic concern. A soft tissue contour was established after operation. 4 years post-surgical for the upper shoulder, good peri-implant, soft and hard tissue healing. If the soft tissue loss is severe, immediate implant is usually contraindication. We did a soft tissue graft before the implant placement. With the intense soft tissue, it's much easier to get a good aesthetic result. If the soft tissue deficiency is minimum, one option is just wait a couple weeks of the soft tissue healing post-tooth extraction. Even with 2 to 4 weeks of the soft tissue healing, there is naturally occurring of the thick labial soft tissue and the interdental papilla. It is beneficial for the soft tissue management during the implant surgery or combined with the hard tissue augmentation. Considering that delayed implant placement may cause the labial bone resorption, a graduate study showed that in the first 2 to 4 weeks, buccal crest bone level was only 0.3 millimeter and 0.9 millimeter apical to the lingual crestal bone, indicating that the buccal bone resorption was limited at the 2 to 4 weeks interval. This case has severe bone destruction. For the optimal extracted, we wait 6 weeks of soft tissue healing. This intact soft tissue will favor flat manipulation during hard tissue augmentation and achieve long-term soft tissue stability. The last thing is hard tissue management. In the immediate implant, the surrounding bone tissue may be deficient. Aliens proposed a simple but practical socket classification based on the amount of the remaining buccal soft and hard tissue. In the type 1 socket, it is predictable for the immediate implant placement. In the type 3 socket, it's very unpredictable. In the type 2 socket, it's in between, depends on the tissue situation. The type 1 socket with adequate buccal plate and soft tissue straightforward immediate implant placement usually get a good result. The type 2 socket, there is loss of the buccal plate, but the buccal soft tissue is integrated. If we plan to do the immediate implant therapy, we got to do every surgical procedure very carefully. I think in this case, the patient has soft tissue sinus tract and extensive buccal bone destruction. After tooth extraction, we use the thin osteotomy to expand the apical portion of the labial plate to create a space for regular size of the implant without sacrifice the labial bone tissue. After ridge augmentation, we suture the soft tissue without primary closure to maintain the soft tissue contour. Our long-term follow-up showed consistently good soft and hard tissue repair. In the type 3 socket, there is loss of the buccal plate and the soft tissue. In the severe loss of the tissue, immediate placement of the multiple implant is very challenging. Therefore, we did a ridge preservation technique before the implant placement. You can appreciate the severe vertical bone loss and the extensive buccal concavity all over the anterior teeth due to a non-spacing making defect. We did a ridge reconstruction using a supporting screw and the barrier membrane. After surgery, abundant bone volume allowed for ideal implant positioning. We designed a supergingival margin for the cementite restoration and for the patient's maintenance. After 20 years, the soft tissue and the crestal bone level of the older implant remain stable. At the end, I made the last view of the point. Immediate implant is a simplified procedure for the patient, but it's not a just simple technique for the dentist. Bone is a foundation. Soft tissue is a critical element. However, the key is our dentist, our mind, our hands. We got to carefully select the case and perform the comprehensive treatment plan and the dedicated clinical procedure. All of these are the key for the successful immediate implant therapy in the anterior area. This is the end of my presentation. Thank you for your listening.
Thank you for Professor Lai. I would like to invite the participant on the web or here to raise any question about Dr. Lai's wonderful clinical experience on the critical thinking of implant surgery. I know there's someone on the web in States. 叶明光学长, are you there? Okay. 薛红要不要问一下老师？This is your rare chance. 你可以 challenge 我们赖老师，就在这时候了。Okay, I'm very interested in the very last case of 20 years maintenance. So I think basically not only to build the infrastructure like bone or soft tissue, the general maintenance is very important. So how often you follow this kind of cases, this kind of comprehensive cases? How often?
At the beginning, usually we have the patient come back every 3 months. Then after a couple of years, the patient's condition is very stable. So we have the patient come back about once a year.
Okay, wow, once a year is a long time to follow. So, very neat. I would say we have a very high quality standing in our perio division. Has been led by Professor Lai for many years. So it's really amazing to see that kind of case. In my cases, I couldn't even see any case 6 months later. Surprised me. So it's very important. Every 3 months. For how long? I mean, every 3 months for how long?
About depends patient's condition. If patient condition is stable, then we just for about a couple of years. Then after that, then we can switch to the once a year.
I think there's a very critical difference is this kind of cases receiving comprehensive implant surgery who has already taken practice for oral hygiene maintenance for a couple of months at least in perio. Yeah. I think that's very important for pre-surgery teaching in OHI. So that no wonder you have such a wonderful results here. So any question here? Okay, so finally let's applause for Professor Lai's wonderful lecture. Thank you, Professor Lai.
各位同仁，今天第3部分，我们很高兴邀请到李承翰医师来给我们介绍这个 Prosthetic 方面的题目。那李承翰医师，大家都认识他，是我们这边实习当住院医师，那这边表现很好，是最佳实习医师也是最佳总医师。那他在这个 Prosthetic 方面他的专长是全瓷冠美学修复、牙齿美白贴片、瓷牙贴片，还有全口大范围修复，还有全口重建那我们现在就欢迎他精彩的演讲。
Hello. Okay. Good morning, everyone, and good evening. Forgive me, I need a memo to achieve better English grammar. Next, I will present to you the complete digital workflow for the multidisciplinary dental treatment. I'm attending physician of the prosthetic department at Taipei Veteran General Hospital. I'm Li Chenghan. First, let me briefly introduce myself. I'm a graduate from the National Yangming Jiaotong University and then complete my specialist training in the prosthetic department at Taipei Veteran General Hospital in 2019. Now, I serve as the chair of the Comprehensive Dental Treatment Center at Yueting Dental Clinic. The prosthetic department is like the warm family. I learned most of my knowledge about prosthetics here. I'm still honored to continue serving this department. And this is my daily workspace, Yueting Dental Clinic. It is a fully digital, large dental clinic. In this clinic, I have access to a wide range of digital dental equipment. And here is a rough overview of the equipment we have in our clinic. I say rough because it is constantly being updated. Currently, we have about 22 intraoral scanners, 2 in-depth CAD systems, 2 sets of ExoCAD and ExoPlan, 20 mini machines, several fillers, and 3D printers. We also have 7 full-time technicians. And this is my team, which includes 1 specialist from each specialty. We are dedicated to treating patients who need comprehensive care within the clinic. Since 2020, I have completed over 1,200 all-ceramic restoration and a few implant prosthetics. And none of these cases use silicone impression. So, in today's presentation, I will use one case to explain my current treatment workflow and provide a brief standard operation procedure. Due to the time limit, I have omitted information unrelated to today's topic from the following case report. This patient is a 14-year-old woman who suffered upper and lower jaw fracture due to a car accident. She has undergone surgery and has healed. Now she needs formal rehab. And this is a panoramic X-ray. We can see that in addition to the fracture, tooth 14 is fractured down to the bone level. Teeth 41 and 22 were also extracted due to being at the fracture site. And intraoral finding, from the intraoral view, the patient shows very little gingival exposure. The big issue is that her midline and horizontal reference line are canted. In our workflow, we use Smile Designer Pro to analyze the patient's intraoral view. This process allows for quick communication with the patient within 5 minutes. It only requires 2 intraoral photos. So it is clear that the abutment position of this patient cannot be directly restored. Orthodontic treatment is necessary. From the intraoral photos, we can see multiple teeth fracture or displacement causing vertical dimension loss and deep bite. As a result, the freeway space has also increased. Fortunately, most of the fractured teeth are still EPT positive. The damage is more extensive in the upper teeth, while the lower teeth, except for the tooth 46, are less affected. And this is the orthodontic evaluation, and it was complete using Invisalign software. In this software, we can use scan data to perform initial tooth alignment and measure tooth sizes. At this stage, the prosthodontist will work with the orthodontist to evaluate the ideal tooth position. It can be seen that the main issue for this patient is the abnormal ball-turn ratio due to missing lower incisors. And this is the self-analysis. We can use the web self-service by minor adjusting the software's recognition of landmark. We can quickly generate a report for interpretation. And here is the patient's report from this app. And here is the summary of the report. It can be seen that we have the spare to restore her vertical dimension. For the patient who may need implant, root canal treatment, or periodontal treatments, we use combing CT to initially assess the condition for their bone and canal. Although the root are tooth 22 is barely sufficient, but it is at the fracture junction, and both tooth 21 and 23 require all ceramic crowns. Therefore, we chose to use a dental bridge for restoration. The bone volume at tooth 14 is quite sufficient. We plan to perform ridge preservation during the extraction, followed by implant placement. Finally, after consolidating the previous analysis, we use the EFSB format to categorize the problem list. This method allows us to clearly see the treatment priorities. The tentative treatment plan involved using the provisional restorations for the extensive damaged teeth and resin fillings for less damaged teeth, followed by Invisalign orthodontic treatment. Near the end of the orthodontic treatment, we will proceed with the implant-related treatment for the tooth 14. And this is the proposal for the tentative treatment plan. So now from the above workflow, you can see our data collection checklist. Among this, I prioritize the intraoral scan is the most because it is easy to obtain and has many uses. It is important to note that the bite scan needs to be taken in the CR position. Deprogramming may be necessary because the original bite position of this patient is often unreliable. Additionally, for me, intraoral photos are more important than intraoral photos because we can help because they can help in adjusting the patient's midline and horizontal alignment. Intraoral scan can, to some extent, replace the intraoral photo. So in simple cases, our data collection will only include these items. In the discussion of the treatment plan, our checklist includes the following items. Among them, digital smile design and diagnostic design are the part I highly value, as they are equal to the diagnostic WhatsApp in the analog workflow. The fully digital data collection and the analytic workflow has 3 advantages compared to the analog workflow. First, it's more efficient. Specialists can view the patient file online and discuss them. We often use Taiwan's communication app 9 to discuss the cases, allow us to work from home without needing to gather around an articulator. The discussion can, of course, also include the patients. The discussion, adjustment, and simulation of the treatment plan are all faster compared to the analog workflow. Second, this entire workflow amounts no consumable materials, making it environmentally friendly and reducing the cost of the clinic. Third, this method allows doctors to be better present the intraoral condition and treatment plan to the patient. If necessary, we can use a markup to transfer and test it in the patient's mouth. Okay, so let's begin the treatment. We started the infection control phase, completing recent filling and first and second provisionals. This is the intraoral scan of the second provisionals. During the CAT, the orientation of teeth should be based on the direction of the roots, and the tooth dimension should refer to the DSD design and bottom ratio. At this stage, it is normal to have occlusal interference. Since orthodontic treatment is required, each teeth is designed separately. And this is how they look in the mouth. Intraoral scan for the Invisalign. Then the orthodontic treatment began. We set up the final tooth position based on the DSD and the diagnostic design model. The orthodontic staging is visible to all doctors in our teams, allow us to track the patient's progress. And 2 years later, when the teeth are near their final position, it's the right time to proceed with the implant placement. After tooth extraction, After tooth extraction and ridge preservation and waiting for 3 months, we proceed with the fully guided implant surgery data collection. We scanned the maxilla at this stage and took a combing CT. And we matched these 2 files into the exoplan. And it is important to have the landmark for the best fit matching. If the entire mouth are provisionals, the corneal bead will be need to assist. Next, we select the implants. We use Ultra EV implants, and this is the guide kit for the Ultra EV. And the drill sequence, which use sleeve and laser marking to control the depth. In exoplan, the prosthodontist and surgeon place the tooth design and the implant position together and finish the guide and 3D printed it. Then we place the implant. Sorry. And the position of implant is basically as designed as in the software. Then the orthodontic treatment was complete. The teeth was mostly reached their final position, except for the rotated tooth 45, which we suspect has ankylosis, and the lingually positioned tooth 14.6. After discussing with the patient, we decided to add an old ceramic crown on the teeth 45 to improve the occlusion. And here's the comparison of the preoperative and postoperative. And here's more photos. Okay. As you can see, the horizontal and midline position have reached the initial design target, and the result was achieved by combined digital smile design and the Invisalign software. Then next, we began the third provisional. We performed another smile design to refine it. At this stage, the patient, for aesthetic reason, want to add all ceramic crown on teeth 13 and 12. Now, all the abutments have reached the position suitable for the restoration. Then I scan the provisional and abutments. This provisional scan is very important because this allows us to use the file as a reference to connect the smile design and the intraoral scan. Then we know the necessary adjustment in two shapes. And this is the design. Since the third provisional is nearing its final design, I use virtual articulator to design the lateral excursion. So this is the protrusion and left excursion. And right excursion. All apply progressive guidance concept and avoid teeth unsuitable for guidance. And this is a third provisional in the mouth. While waiting for the implant to heal, I completed the all ceramic crown for teeth 14.5 and 14.6. In this case, I chose monolithic 5Y TZP multi-layer zirconia. And this is the preparation and the scan. Because there is still space to the opposite teeth, the occlusal surface was minimally prepared, and it's delivered. Then the implant have been waiting for 6 months. It's time to complete the entire treatment now. I use the same implant guide as a reference to locate the implant, aiming for minimal tissue trauma. At that time, we could also see that the ovate pontic has formed the papilla. After exposure, I connect the scan post and scan it along with the other abutments. At the same time, I refine the abutments and perform color masking on teeth 11 and 21. And this is scan. The same, I scan the patient's third provisional, which is the shape the patient has already adapted to. And all we need to do is to copy it into the final processes. And you can see the scan post was well recognized in the SOCAD. This is the final design. And then milled and sinter them. And this printing model is for staining and glazing. Now I use Panavia universal resin cement for delivery, and with sandblasting the interior surface and using temp and DP conditioners. And after delivery, the intraoral photos. The results closely match the initial design. Here are some comparisons. We can see that the vertical dimension has been rebuilt. And more photos. And the X-ray. So this is the entire treatment flow. Basically, the workflow is similar to the analog workflow, and it's suitable to the most of the multidisciplinary cases. So what are the benefits of our complete digital workflow? First, it allows for precise implementation of treatment plans because all specialists have the digital model of the treatment plan, working toward the same clear goal. It also helps track each specialist's progress so everyone knows when they should go on the stage. Second, in digital workflow, all steps are repeatable. For example, if a professional restoration is lost during orthodontic treatment, we can simply mail it from the original files. At the same time, when fabricating the final processes, it can replicate the provisional precisely, just like cross-mounting in the analog workflow. Okay, so here's today's presentation. I'm sorry for it's only 20 minutes, so I can only give you a quick overview. The detail of this entire workflow has previously covered in a full 3-day course. If there is a chance, I'd love to share more with you in the future. Thank you for joining us this morning and evening.
Joe, but I want to ask a question. Okay. Do you use only one iTero intraoral scan, and throughout the treatment procedure, you use mainly software?
Yes.
Including also implant?
Yes.
Can you summarize for us?
Summarize
your tool.
Okay. We use PriceScan and 3Shape Trial 3 for the intraoral scanner. And the software we use Surrot for the prosthetic design and ExoCAD for the diagnostic WhatsApp design. And ExoPlan for the implant surgery guide design. So we have this software. And the mini machine we use Surrot MCSL and MCX5, and the 3D printer we use Form 3. Yeah, so that's all our equipment.
So you use two kinds of intraoral scanner.
Yes.
iTero and the use.
We have PriceScan and Trial 3, and PriceScan is for the large scale cases because it has much more better stitching ability, and the Trials is for the simple cases because when used to long range, it might be some kind of the distortion. Yes.
Is there any question here?
Thank you, Dr. Lee, for your very outstanding and inspiring speech. And I have a question about how do you superimpose with your master cast and your temporary restoration, since that the upper arch only have 2 second molar left. Do you have any difficulty encounter when you are superimposing?
Okay, you captured a very important point because when the full upper arch is provisional and the scan and the abutment scan is full abutment, it's difficult to match 2 files. So if it is an upper arch, I will use the palette to match 2 files. But when it goes to lower arch, we don't have the palette. So at that time, we have to finish the final processes with 2 scans. The one scan is full arch with the provisional and partially remove the provisional with abutment. So we can match 2 files with the remain provisional. And the second file is this file to match with the all abutment models. So the previously abutment can match the rest of the abutments. So I call it the digital cross-mounting. Yes.
Okay, thank you. There is a question from Los Angeles from Dr. Ye, who is our Yangmi alumni. So his query is regarding the timing of bone grafts in ortho case. Will the scar tissue from the buccal bone graft interfere with the Invisalign tooth movement if we want to increase bone width while we are still in the late stage in ortho treatments?
Because we already know the final implant position is near the original root position, so we don't have to make long distance of the tooth movement. So we decide not to lose the teeth for too long time to avoid the bone resorption. But if the tooth want to move longer and the bone need to be rebuilt, and for the orthodontic treatment like PA or something, so when in this situation the teeth should be removed early. Is that clear? Okay. Sorry, my English grammar is not so good.
Okay. Okay. Thank you, Dr. Lee. So anyway, it's about time for the ending. I saw Nadim is still online on the web, so thank you very much. This is really a wonderful time to have for the connection from lots of alumnus in Taiwan, from Tufts, and in States. Anyway, I also see Dr. Zhang Wei still on the web. She's a part-time faculty in Tufts. And so I really want to express my gratitude and sincere appreciation to the Dean, Nadim Karenbachs, give us a very wonderful lecture and very wonderful beginning of connection in the future. So thank you, Nadim. I really hope that we might have a chance to invite you to be our guest next year. Let's work it out.
Yeah, looking forward to it. And any people are welcome to visit us at Tufts if they're in Boston.
Yeah, well, certainly. Once we have any chance to send out our fellows like Liu Yanjun, she was there a couple months ago staying in Boston. I think she liked Boston pretty much. And certainly we have lots of fellow staffs like Professor Lai. She's a very outstanding alumnus from Tufts here working in Taiwan. And of course, in the future, we might have chances to send our fellows for short-term continuing education or even continuing education in distance. So let's work it out. And thank you, Nadim. Thank you very much.
Thank you. Yeah, thank you so much.
Thank you.
Bye-bye.
Yeah, bye-bye. So 在最後, finally, I want to express my gratitude to all the participants here and on the website. Of course, as you know, the Tufts University Dental School is one of the largest dental school in States, also providing very high tier and very high quality continuing education. So in the future, we will continue our work, and thank you very much. And especially want to thank you for Professor Lai and everyone participation here. 我们 have a good photo here. Good. 我们几位吧，先来照一照，历史的留念。开卡。